Over the past 30 years, the rates of maternal mortality and morbidity in the United States have more than doubled. This is in stark contrast to the rest of the world, which is seeing overall decreases. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Petterly, senior writer for AHA. Maternal and child health has long been a priority for the AHA. Recently, it established a strategic plan to better support hospital and health leaders as they improve outcomes for mothers and babies across the continuum. One part of this work is our Better Health for Mothers and Babies initiative that aims to eliminate maternal mortality and reduce morbidity related to childbirth. On hand to discuss these efforts today are two distinguished experts. Ginny Trainor leads AHA's maternal and child health improvement work. She's joined by Robyn Begley, Senior Vice President and Chief Nursing Officer for AHA, and AONL's Chief Executive Officer. Among other things, Robyn will share her experience starting as an OB nurse and talk about AHA strategies to address maternal morbidity and mortality.
Hi, Robyn. I wanted to talk to you about maternal and child health, and I know you started your career as an OB nurse. Will you share a story from that experience that made a lasting impact on you?
Be happy to, Ginny. As a new RN with about 4 months under my belt, I was finishing my evening shift one evening on a postpartum unit. I was concerned about one of my patients, a new mother of twins. I recall that she and her husband were over the moon about their new babies as they had had infertility problems for a number of years. Looking back again, I believe they were both in their late 30s. At the time, this was considered late in life, especially for a first pregnancy. My patient didn't look right to me at the end of my shift, although all of her postpartum indicators, for example, her vital signs, were normal. And I remember saying that to the oncoming nurse as I was giving report. The next morning, I was working, we called them double backs at the time. I went home and got some rest and then came back in the morning to start a double shift. The next morning, I came to work to find my patient absent from her room. And I could tell by looking at the room that it was terminally cleaned. So I ran out to the desk and asked where my patient was and learned that she had coded and died around 4 a.m. that morning. Mm-hmm. Later came to find that the cause was an amniotic embolism, a rare but usually fatal complication. But all I can ever remember is, finding the dad in the nursery, sitting in a rocking chair, rocking both of his babies with tears running down his face. And I have thought about that for the past 40 years of my nursing career.
Wow, what a traumatic experience. From that, if you can share from that, it's obviously very vivid for you still. What are a couple important lessons that you learned that you think would be helpful for others, or changes that were implemented as a result, or things you wish were implemented?
Well, the first lesson for me personally was, as a clinician, as a nurse, trust your instinct. And I have so many times gone back over that shift and thought, was there something else that I should have done? Should I have, alerted someone? But being a new nurse with 4 months experience, maybe I didn't trust my instinct or my gut as much as I should have. I think the second lesson, in retrospect, and at the time I don't know that we were so immersed in the quality and safety movement as we are today, but really every practicing nurse needs to examine her or his role in quality and safety and what is our responsibility. So, making sure that we forward or we raise issues that we believe need a deeper dive.
And despite, you've talked about how things have changed with safety, and despite the many advances in healthcare, we have seen the rate of maternal mortality rise in our country. In the last 30 years or so, the rate of maternal mortality has more than doubled, and the rate of severe morbidity has tripled. What are some of the opportunities hospitals have to improve both maternal mortality and morbidity?
So we at the AHA have developed a 4-part action plan for hospitals and health systems. This plan highlights some of the opportunities that we have to improve, quite frankly. The first step is to evaluate and act on data. We believe that improved data collection and assessment will allow hospitals to improve their outcomes. By examining what is happening in their hospitals, leaders have an opportunity to better design and implement programs for women that are targeted at conditions that lead to mortality. This includes obstetrical hemorrhage or severe hypertension. The second part of our action plan is to examine disparities. Hospitals can then take that data and look at it in different ways. And for example, they can look at the demographics of the patients and communities they serve. They have a tremendous opportunity to adapt the programs they offer to meet the unique needs of their patient, each patient, but also their patient population. In addition, when looking at disparities, hospitals have the opportunity and the responsibility to address unconscious and implicit bias. We know that the rate of maternal mortality is 3 to 4 times higher for Black women, and we need to provide education and awareness around this. This is not acceptable. Our third step is to engage mothers and families. We can do a better job at engaging our patients and their families, and in some ways include engaging patient and family advisory groups to improve care for new and expectant mothers. It could also include establishing a team-based approach to care that helps to make sure that women play an active role in their care. Hospitals can also create ways for postpartum moms to connect with key community providers and provide additional resources and support for moms in more vulnerable socioeconomic situations. And the fourth step of our action plan is to partner with clinicians and stakeholders in the community. So hospitals and healthcare organizations can also engage community partners and outside resources. They can bring social services and outside organizations into the team from the very beginning to ensure the patient has support and resources for a healthy pregnancy and postpartum.
Great. Thank you for sharing that. And we know that the U.S. has the highest rate of maternal mortality. But when you look at the actual numbers, it can seem low. Why is it important for hospital leaders to make maternal and child health, specifically mortality and morbidity, a priority in their hospital right now?
I think that's a good point, Ginny, because of the approximately 700 deaths per year in American hospitals. You know, the number is too high. One death is one death too many, but 700 over the thousands of hospitals means that, you know, hospitals could go a number of years without experiencing a mortality. And that's wonderful, except that I think it gives us a false sense of security in the field, perhaps. So as a field, we really need to focus on eliminating mortality, and that includes reducing preventable complications related to childbirth, because those significant preventable complications can lead to mortality. As hospital executives, as a group, they have a strong commitment to women's health. A healthy pregnancy and a good start for all children is really key to improving our nation's health. And I know hospital executives are stepping up here and implementing the action plan at their organization, even if they have not, experienced, the tragedy of a maternal mortality. So focusing on maternal and child health will allow hospitals to promote value. We know that a healthy pregnancy and delivery means better clinical outcomes, enhancing our patients' experience, and also can decrease overall healthcare costs. I have an example. Penn Medicine implemented a pilot program called Heart Safe Motherhood. Understanding the barriers patients may have with regard to things like transportation that may prevent them from keeping appointments, Penn Medicine provided a blood pressure monitoring program. Each patient was provided and educated on how to use a blood pressure cuff, and using an app, texting, and message check-ins, they were able to remotely monitor the well-being of their moms. knowing that the first week after delivery is when women have the greatest risk of worsening blood pressure, Penn sent text reminders twice daily for 10 days to remind mothers to take their blood pressure and share the results. About 90% of the women enrolled actively participated, and I think that's a great, compliance rate. The medical team were able to safely adjust blood pressure meds while decreasing postpartum hypertension readmissions. It has been so successful that they are rolling it out at all the other hospitals in the UPenn health system. They've described it as a low-cost and easy solution for a big problem. This is just one example of how a system identified the problem. And they were innovative with finding a solution that was not only cost-effective, but improved patient experience and produced positive outcomes.
What is the AHA doing to help hospital leaders in that work?
Based on feedback from our Mothers and AHA board, the AHA has made maternal and child health, and specifically our Better Health for Mothers and Babies effort that is focused on maternal mortality and morbidity, a top strategic priority. We're developing tools, resources, and education around each of the 4-part action plan that I previously described. I think one that will be most helpful to hospitals as they take on this work is our Members in Action case study series. Here, we highlight proven strategies implemented by hospitals around the country that can improve maternal mortality. For example, Dartmouth Hitchcock in New Hampshire and Metro Health Center in Cleveland have shared how they address the opioid crisis specifically with regard to pregnancy and neonatal abstinence syndrome, also known as NAS. Sharing their obstacles and challenges along with their successes has been beneficial for leaders to learn what has worked with other health systems. We are also sharing a number of key resources that have been developed by our partners in this work. For example, ACOG, AIM, and the California Maternal Quality Care Collaborative have been persistent in their research and advocacy for providing outcomes for maternal and child health. They have also developed things like patient bundles, universally implementable evidence-based standardized processes that have been shown to improve outcomes and quality of care. And as we look to 2020, we will be hosting education at a number of AHA meetings throughout the year. In addition, we are hosting our first executive forum on maternal and child health in Austin on April 7th. This meeting will bring together leaders in the field addressing issues related to maternal and child health, specifically maternal mortality and morbidity. Hospitals and health system leaders will have the opportunity to learn how to implement each part of AHA's Better Health for Mothers and Babies 4-part action plan, as well as networking and learning from other hospital leaders. We are also working to develop a team-based approach to maternal care and will be releasing a number of tools and resources to help our members take this on, including a team training masterclass later in the year.
Wow, it sounds like the AHA is doing quite a bit. Thank you so much, Robyn, for your time, for sharing your story, for sharing some of the stories of AHA members. This has been very helpful, and we're so appreciative of your time.
My pleasure, Ginny. Have a great day.